Thank you, Mr. Chairman. I like that point, Mr. Miller, that you made about bringing forward the physicians, because oftentimes the people in the system can tell you how to solve those problems. And so I look forward to working on that as one of the solutions. I'm going to switch to you, Ms. Mitchell. You describe geographic disparities in quality and cost of care within your own state of Maine, with vast potential for qualitative gains and cost savings if best practices are widely adopted. And I guess I'm curious, how do you describe, or how would you suggest that we achieve this geographic parity, and keeping in mind that I'm also looking not just at specialties, but the fact that I have a large rural district with lots of small communities. Some of my counties, have less than the 5,000 people necessary to do one of those new bundling formats that we were talking about with the previous speaker.
Well, I think the good news is that you don't need a lot of people to do this. Maine is equally rural, as I'm sure you know. Yep. And what we were able to do was bring physicians, employers, patients together to look at the data and really look at the variation. We found opportunities to reduce, for instance, cardiac spending by $35 million just by getting to current best practice levels within the state. This is not unattainable, it's actually being done. So when you facilitate not only that information being shared, but then bringing those best practices to the other areas, there is a lot of learning. You need technical support, you need information, you need feedback loops. All of those can be done at the local level. We also found massive variation in early induction. And just by sharing that data statewide, we saw up to a 20% reduction in those rates, because they understood that that needed to change and that what best practice targets were. So sharing information in and of itself is a very powerful practice. It does not require an ACO to do that. It requires engagement and data of the with the physicians.
Which would be an amplification of what Mr. Miller was saying.
Absolutely.
Okay. And Mr. Miller, how do you encourage the physician buy-in, particularly in rural areas where you may not have sufficient numbers of docs to begin with?
Well, I think there's two ways. First of all, you have to spend the time to help physicians understand the model and to be able to get the data that they need to understand how this will work for them. I've found when I have done programs, and I did a program last fall for the Medical Society of Virginia, we had physicians from all over the state came in and spent a day actually working through the payment models, episode payments, comprehensive care payments for chronic disease. And after they had a chance to work through them, we took a little straw poll at the end and said, so which model would you rather be in, the current model or this model? And almost unanimously they said the new model. But then the question is, how will that work for me? Because it does come down to what's the price. And nobody actually knows today. They don't have the data to be able to do that. So if we can get them the data, and it's not just data, it's actually turning it into information. So simply handing a physician, 7 multi-million claim record files from Medicare is not the answer. They're going to need help, and they need to get that help from some trusted local entity. The kind of thing that Elizabeth Mitchell runs in Maine is a place where physicians have a seat at the table and have the access to technical assistance that they trust. And then some assistance in being able to transform the way they deliver care. And I think that if you then go to a rural area and you say, well, how will this work here? And what tweaks do we need to be able to make in that model to make sure that it does work here, given that patients may have longer travel time, et cetera. But the flexibility of the model means that you can actually design a different system in a different place. You might say in a rural area we need to be able to do more telemedicine to be able to try to bring resources into unpopulated areas, then we can do something different in an urban area. So I think that's the real advantage of these flexible payment models, is they would actually give physicians the flexibility to design different care delivery systems that work in different communities.
Well, I appreciate that, and I would have to tell you that I am not surprised that if you went to talk with the Medical Society of Virginia that you got some interesting ideas. I served in the state legislature for 17 years and worked with them on a regular basis on a number of issues, and it's a good group of people who are out to solve problems. They are looking out for their territory, but they're also out to solve problems, and they've always been that way. I appreciate it very much, and I yield back, Mr. Chairman.